Hello, welcome to Chapter 26, the urinary system. So we're going to go through all the different parts of the urinary system and how they all work. The urinary system has two kidneys. Attached to those kidneys, we have two ureters. Those two ureters are going to drain into the urinary bladder. When it's time to excrete, that urinary bladder is going to open up into the urethra. Our kidneys are filtering out our blood, and they're getting rid of any kinds of wastes, excess fluids. As this stuff gets filtered out, it drains into the ureter, which is going through the bladder, which is then going into the urethra once that bladder has reached a certain point. So in the urinary system, you can see the two kidneys, they sit retroperitoneal. So they sit in the back behind most of the abdominal contents. They technically are covered by those 11th and 12th ribs, those floating ribs in your back. The kidneys are draining into the ureters. These ureters empty into this urinary bladder, and when it is time to excrete, that urine will travel through the urethra to leave the body. So what does our urinary system do? Its functions, they're going to regulate your blood volume. They're going to regulate decomposition, so the amount of those different chemicals found within your blood. By regulating blood volume, they regulate blood pressure. They can get rid of those hydrogen and bicarbonate ions, so that changes our pH. Your glucose levels, they can help to excrete out glucose. Your kidneys also produce calcitriol and erythropoietin, and they excrete out these different wastes from your blood. The ureters, they're used to transport. The bladder stores and expels. Then that urethra discharges. So this excretion of wastes, all of our cells, as they're going through their metabolic processes, they are creating different waste types of products. These waste products diffuse or enter into the bloodstream, where these kidneys are going to filter this blood and get rid of these different waste products from our cells. Some of these excreted out, as I said, are from those metabolic, like urea, ammonia, creatinine, uric acid, urobilin. Urobilin is a nitrogenous waste, so it also has nitrogen in it. It regulates the potassium of your blood. Those ions, because that's sodium, potassium, calcium, chloride, phosphate. All of these different ions are being monitored and by the kidneys, and they get filtered out of the blood. We need to regulate the blood pH. Again, those hydrogen and bicarbonate ions. Hydrogen, too much hydrogen will start to make that blood too acidic. Too many bicarbonate ions will make that blood too basic. So we need to regulate how much of that hydrogen and bicarbonate is found in the blood to regulate the pH. Blood volume. So those kidneys are going to either conserve or eliminate water into that urine, because an increase in blood volume increases blood pressure. A decrease in blood volume decreases this blood pressure. So we're trying to regulate that blood pressure, keep it within a certain range through the excretion of water into the urine. By regulating blood volume, we regulate that blood pressure. We maintain that blood osmolarity. So we can regulate the loss of water and those different solutes in the blood. We can regulate all of this by keeping the blood osmolarity close to this 300 milliosmoles per liter. Going back to this regulation of blood pressure, the kidneys will secrete renin. Renin starts that renin-angiotensin-aldosterone pathway, and this works to increase your blood pressure when renin gets secreted by the kidneys. It's another way to regulate water volume in the blood. Then those hormones, calcitriol, it activates vitamin D because we need vitamin D for calcium to be picked up from the digestive tract. And that erythropoietin stimulates the production of red blood cells. Then that blood glucose level. The kidneys can use amino acids, specifically glutamate, in gluconeogenesis. So they can form new glucose from the amino acid glutamate to get the energy that those cells need to be able to make the specific, or get the glucose to get the energy that they need. They can also release that glucose if there's not enough glucose in the blood. So our kidneys are kind of this kidney bean shape, which is why they're named kidneys, because of their specific shape. They are, it says, between the peritoneum and that posterior abdominal wall, which makes them that retroperitoneal. They are somewhat protected by those 11th and 12th ribs, as I had mentioned before. If there's any fracture to those 11th or 12th ribs, it can actually puncture the kidneys and cause life-threatening damage. It could possibly kill you. The right kidney does sit a little bit lower than the left kidney because of that liver, just because of placement of those organs and where there is space. So that right kidney sits just below the liver on the back side versus that right side, or that left side. That right kidney, that left kidney sits a little bit higher. So here's, if we take a slice at the second lumbar vertebrae, we can see both that right kidney and that left kidney. Our kidneys are surrounded. They have a fascia, they have a perineal fat capsule. This is helping to protect those kidneys. They are surrounded by fat to help protect. So a normal adult kidney is about 4 to 5 inches long, 2 to 3 inches wide, and about an inch thick. It's going to be more concave towards that vertebral column, because in this area that's more concave here, we have what is known as the hilum. The hilum is where blood vessels go into the kidney, veins come out, nerves go into the kidney, and that ureter comes out. As I mentioned, we have that fibrous capsule, then there's fat that surrounds it. This fat works to protect. And then we have renal fascia. This fibrous capsule is the most inside one that surrounds that kidney. The renal fascia is the one that lines the outside. So here we can see a kidney. You can see this hilum, which is this kind of opening, or this in part that concave part that goes in. We get arteries that go in, veins that are coming out, and then this ureter coming down. You can see the same thing on a real kidney. You can even see they were able to save the renal or adrenal or suprarenal glands. So here we can see the renal fascia, that's the outermost portion, that perineal fat, that's the middle layer, and then this fibrous capsule that lines the actual kidney. So once we get inside of the kidney, the inside of the kidney has a lot of different things happening because there's a lot going on. We have the renal cortex. That is the outermost portion, and in that cortex, we have renal columns. We have the renal medulla. In the medulla, we have renal pyramids. They are cone-shaped like a pyramid is. We have a renal papilla. This is at the bottom, and it points towards that renal hilum, and this is where urine is draining into that hilum to go into that ureter. The parenchyma. This is the renal cortex and the renal pyramids. And this is technically considered the functional portion of a kidney. In this functional portion, we have what are known as nephrons. We have at least 1 million nephrons per kidney. This is in the nephrons is where we are making this filtrate or fluid that is going to turn into urine. This filtrate is going to drain into the papillary ducts through part of that renal papilla. And this is all happening kind of within those renal pyramids. So we also have minor and major calyces. So these kidneys can have anywhere between 8 and 18 minor and 2 to 3 major calyx or calyces. Each minor calyx is going to receive this filtrate or this urine from these papillary ducts. They deliver this filtrate to the major calyx. So once the filtrate is entered the calyces, we no longer are able to reabsorb anything that was originally filtered out. The major calyces is going to take this filtrate and it's going to drain this filtrate into the renal pelvis. The renal pelvis is where this filtrate is going to enter into that ureter, into that urinary bladder. Part of the hilum was where we have the renal sinus. This is where the renal pelvis, the calyces, and the branches of the renal blood vessels and nerves are found. Again, we're going to find some adipose tissue because this is helping to stabilize that renal sinus. So let's look at all of these different parts. You can see the cortex. It's in the lighter color. The medulla. The medulla is marked here in one of these pyramids. Each pyramid is this kind of triangle shaped figure here. So each of these pyramids, this is 1, 2, 3, 4, 5. This has 6 pyramids in it. The columns is the space between the different pyramids. The renal papilla. This is at the very bottom portion here. The renal sinus that I had mentioned. This is a sinus. It's a little bit of an opening through here. We can find the minor and the major calyces. The minor calyx are these little portions through here. They are going to drain into that major calyx, which comes out through here, this kind of whole area, really. And then it kind of continues to that renal pelvis. That's right at the opening of this kidney. That's the renal pelvis, which goes to the ureter. The kidneys have a very large blood supply. The actual arteries that are going to the kidneys are quite large because it gets rid of our cells' waste products. It regulates that blood volume. It regulates the different ion levels within our blood. So for this to actually be able to happen, there needs to be a large amount of blood that is coming through. So each renal artery gets 20 to 25% of that cardiac output. Our kidneys are going to receive quite a large amount of blood, 1,200 milliliters of blood per minute. These renal arteries, once they enter into the kidneys, they turn into segmental arteries. These segmental arteries are going to branch off into interlobar arteries. So a kidney lobe, it was drawn up here. This kidney lobe is the whole cortex in the medulla through. This is what makes up an entire renal cortex. So at the base of these renal pyramids, these interlobar arteries are going to branch into arcuate arteries. These are further going to branch into cortical radiate arteries, which are going to branch even further into afferent glomerular arterioles. So these afferent glomerular arterioles, this is how far we've made it down. We get to the renal artery, to the segmental, interlobar, arcuate, cortical radiate, afferent glomerular capillaries. We zoom in here. The afferent means they're entering into this glomeralis. This glomeralis is this whole circular portion through here with these glomerular capillaries inside. These glomerular capillaries are going through to these efferent glomerular arterioles. Then we go to these peritubular arteries or capillaries, peritubular veins, cortical radiate veins, arcuate veins, interlobar veins, renal vein, leaving the kidney. So these arterioles, or these capillaries that come off, as they leave that glomeralis, they're going to travel and follow these peritubular capillaries that are drawn technically in purple, are going to follow the flow of this filtrate that is being made. So each nephron, a nephron again is that part that filters out the different contents of the blood. It's the functional portion that actually does all the work. Each of these nephrons is going to receive one afferent glomerular arteriole. It's going to go through that glomeralis, which is that ball-shaped or circular type of portion of this kidney that filters most out. After this afferent glomerular arteriole has gone into this glomeralis, it comes back out as that efferent glomerular arteriole, which is then going to go into these peritubular capillaries. These glomeralis, or glomulari for more than one, plural, they're part of the cardiovascular system. They're part of the urinary system. They form urine. They are also going to filter out water to maintain that blood pressure. We skip the glomerular capillaries here. These glomerular capillaries is what's found inside that glomeralis, because capillaries are where most of that filtration happens. The vasa recta. The vasa recta are these different arteries that are traveling along this different area of the nephron. This vasa recta is going to become these cortical radiate veins, which become the arcuate veins, the interlobar veins, to the renal vein. The kidney is supplied by the renal ganglion, and it gets this and goes through that renal plexus to get to that renal ganglion. What they're doing is they're helping to regulate the amount of blood that is flowing through the kidneys. So it can cause vasoconstriction or vasodilation of those afferent glomerular arterioles. It's going to regulate how much blood is going into those glomeralis. So these nephrons, we kind of went through the blood supply as I pointed out the nephrons, but these nephrons are what do all the filtering and the formation of this filtrate, which is what becomes urine. So we have that renal corpuscle and we have the renal tubule. The renal corpuscle is filtering blood plasma. The renal tubule is where these filtered fluids pass and they get further regulated. So we could be getting rid of more stuff. We could be reabsorbing more stuff, different ions, fluids. It just depends. So within this renal corpuscle, we have that glomeralis, which has those glomerular capillaries. And then we have that glomerular capsule, which is also known as the Bowman's capsule. That's what I learned it as. When this afferent glomerular arteriole goes inside of this glomeralis or glomerular capsule, Bowman's capsule, this blood plasma gets filtered. We're going to get rid of quite a few, get rid of a lot of water, a lot of ions, could be getting rid of glucose, hydrogen bicarbonate. Everything that gets filtered out is going to pass into this renal tubule. This renal tubule has the proximal convoluted tubule. This is what is attached to that glomerular capsule. So this is that first area, convoluted, because it kind of weaves and goes all over the place. We have the nephron loop, or the loop of Henle, and then we have the distal convoluted tubule. Convoluted because it's coiled. So that distal convoluted tubule enters into the collecting duct. These collecting ducts come together to form papillary ducts. These papillary ducts drain into those minor calyces. The whole nephron loop, we have proximal and distal convoluted tubules. That proximal is because it's closer to that glomeralis. That's what makes it proximal. Distal is because it's further away from that glomeralis. That is where the proximal and the distal names come from. So most of these nephrons are cortical nephrons. So they are found in that cortex. They have a short nephron loop, and it's mostly in that renal cortex. The rest of them are juxtamedullary nephrons. So their corpuscles are going to be in that renal cortex, but it's close to that medulla. They're going to have a lot longer of a nephron loop. So these longer nephron loops are going to get their blood supply from these peritubular capillaries and the vasa recta. This ascending limb has a thin limb and a thick limb. So here's a picture. So here's a renal corpuscle that has that glomerular capsule with that glomeralis, which is all that blood supply. This is where most of the filtering of our blood takes place. We filter out the most stuff. So as blood, or this filtrate now, leaves this renal corpuscle, it's going to go through this proximal convoluted tubule because it's all coiled up. Now it's going to go through this nephron loop. As it goes down, here's that thicker portion of the descending. It's descending because it's going down. This is the thin portion because it's a lot thinner. Then we have the ascending limb. Now we have the distal convoluted tubule, distal because it's further away from that renal corpuscle. That distal convoluted tubule drains into those collecting ducts. So here we go further. Here's with all of the blood supply coming in. So we have that afferent glomerular arteriole that is going into this renal corpuscle or glomerular capsule. Everything is getting filtered out. Now we have that efferent glomerular arteriole. This is coming out, and then it starts all of these blood vessels that are wrapping around the proximal, or the proximal convoluted tubule, the descending loop, the ascending loop, then the distal convoluted tubule, going over to this collecting duct. There's blood supply all along this until we get to that collecting duct, because and stuff that we had filtered out originally can now be reabsorbed, things that we may need. We sometimes filter out more stuff than we need. We may need to reabsorb water back. We may need to reabsorb sodium back. We may need more calcium back. We've talked about different hormones and how these different hormones help regulate some of this stuff. These different hormones are causing the kidneys to reabsorb some of this, these different ions. So here's a juxtamedullary. So this juxtamedullary, the only difference, you can see just how long this proximal and distal loop or limb of that ascending and descending nephron loop is. So that proximal or that descending limb, that ascending limb, it's a lot longer. It's a whole lot longer. Still, there's lots of blood supply throughout. So this glomerular capsule. This glomerular capsule, they are modified stratified squamous or simple squamous cells, simple squamous, that are known as podocytes. These podocytes have these little foot projections that are going to wrap around these glomerular capillaries, and they're going to kind of form a wall. That's on that visceral layer. We have a parietal layer because it's a double layered. Again, they're simple squamous cells. And so that fluid or this filtrate that is being filtered by these glomerular capillaries go into this capsular space. And it's between these two layers. So let's look. We can see all of these different podocyte cells that are wrapping around these capillaries. Anything that gets filtered out goes into this capsular space that is going to go into this proximal convoluted tubule. The proximal convoluted tubule is simple cuboidal epithelial cells with microvilli. The microvilli is going to increase the surface area for reabsorption and secretion because we can still get rid of stuff from the bloodstream, but we can also reabsorb certain things that we may need. The descending limb and part of the ascending limb are simple squamous. The thick portion is simple cuboidal or low columnar cells. That ascending limb that comes in contact with the afferent glomerular arteriole, they are columnar. That's known as the macula densa. We also have juxtaglomerular cells in here. And this is what makes up the juxtaglomerular apparatus. This monitors our blood pressure in the kidneys. So that distal convoluted tubule, it's just past that macula densa. And it's just before that collecting duct, we're going to find principal cells. This is where antidiuretic hormone is going to attach. Aldosterone is going to attach to these principal cells. We also have intercalated cells, and they're going to do the blood pH. So that homeostasis, maintaining our blood pH within that 7.35 to 7.45 range. Those collecting ducts drain into those papillary ducts, and those are lined with simple columnar epithelium. Your number of nephrons stay pretty consistent. Even though our kidneys do increase in size as we grow, and it's actually those nephrons are growing. If you injure your kidneys, injure any of those nephrons, new ones do not form. Kidney dysfunction you don't know that your kidneys are not functioning until there's a decline to less than 25% of normal. Surgical removal of one kidney stimulates that other kidney to hypertrophy, to get larger, to be able to take on more work. So that remaining kidney can filter 80% of the blood that the two kidneys can. So your new kidney grow, or your remaining kidney does grow quite big. So these charts are nice because they go through where in this nephron these cells are located. So that proximal convoluted tubule, we have that simple cuboidal. That descending limb and ascending limb, we have that simple squamous. The thick portion of that nephron loop is simple cuboidal or low columnar. Most of that distal convoluted tubule is simple cuboidal, and the last part of that distal convoluted tubule and all those collecting ducts are simple cuboidal epithelium that have principal and intercalated cells. So renal filtration. What happens when blood enters the kidney? It gets split off all those different places where it's finally going to go to the glomerular or afferent glomerular arteriole. This is where glomerular filtration takes place. This is the first step in urine production. So when this afferent glomerular arteriole goes into this glomeralis, this renal corpuscle, those glomerular capillaries, they filter out water and most solutes. They filter and take all of this into that glomerular capsule, which is going to go into those renal tubules, those proximal convoluted tubules, the renal nephron loop. Then we start tubular reabsorption. So we filtered out a lot of water, a lot of solutes. Now we need to reabsorb what we need. So these different fluids that are traveling through these different renal tubules, they're going to reabsorb 99% of what has been filtered out. So 99% of the water and any useful solutes are going to be reabsorbed. It happens through these peritubular capillaries and that vasa recta that is following that proximal or that descending and that ascending loop. That proximal convoluted tubule, that's where a lot of this is taking place. And then we have also, while we are doing tubular reabsorption, we are also doing tubular secretion. We are secreting other wastes, drugs, too much ions. So we're getting rid of other stuff as we are still going along. So as these different solutes are getting filtered out, they go through those nephron loops, they go through those collecting ducts, they're going to drain into those major and minor calyces, which drain into the renal pelvis, which goes into those ureters. So the rate of urinary excretion of any solute is equal to the rate of glomerular filtration plus its rate of secretion minus its rate of absorption. So by filtering, reabsorbing, and secreting, this is how we're maintaining our blood composition, our blood pressure, our blood's pH. We're maintaining this homeostasis of everything within our blood. So this glomerular filtration, this glomerular filtrate, once it gets filtered out of the blood, it is considered filtrate. We have this filtration fraction. So a fraction of this blood plasma in the afferent glomerular arteriole of the kidney becomes glomerular filtrate. This filtration membrane, so those glomerular capillaries that have those podocytes that wrap around those capillaries, they form a very leaky membrane. We can get rid of water. We can get rid of small solutes. But it prevents filtration of most of that blood plasma. Those blood cells still need something to float in, so we can't get rid of all of that plasma. So when this filtrate is being formed, it has to travel through 3 membranes or 3 barriers. So those glomerular endothelial cells, because we have fenestrations or pores that's going to allow different substances to pass. Mesangial cells, they're kind of among these glomerular capillaries. We find them between the afferent and the efferent glomerular arterioles, and they help regulate glomerular filtration. There's a basement membrane. They have to travel this filtrate has to go through this porous basement membrane. Negative charges, because of glycoproteins, actually are going to repel plasma proteins and prevent them from leaving that plasma. Pedicels, these are those foot-like processes from those podocytes. They wrap around those glomerular capillaries. They provide these filtration slits, and this slit membrane that's going to allow different molecules to pass through. This filtration or this filtrate that is being formed is because of the pressures to force these fluids and solutes through the membrane. So we're still using different pressures to allow whatever is passing by to be able to pass through this membrane. So our volume of this filtrate tends to be much larger than other capillaries, because these glomerular capillaries, they give us a very large surface area. They're very long and extensive. These mesangial cells, they regulate the amount of surface area available. So a contraction is going to reduce the available surface area, and glomerular filtration does decrease. The filtration membrane is very thin and porous. It has several layers to it, but it's only 0.1 millimeters thick. Glomerular capillaries are a lot leakier than most other capillaries, just because we are trying to filter out any substances that we do not need. The blood pressure in glomerular capillaries is quite high. Again, we're using those different pressures to move things across that membrane. That efferent glomerular arteriole has a smaller diameter than that afferent. And that actually creates more resistance. And as we create more resistance, it causes that higher blood pressure. Those glomerular capillaries, that blood pressure is higher than the blood pressure and capillaries everywhere else in the body. Again, because those capillaries are smaller, which makes that resistance higher. Higher the resistance, the higher the blood pressure. So we can see the fenestrations in these capillaries, these pores, these blood vessels are very porous. There's a lot going on in there. That basement membrane is still very thin. And then these podocytes, they have these large slits between these little foot-like processes that allows a lot of filtrate to be formed. Here we can see these layers, and you can see an electron micrograph of how this is actually set up. You can see how easy it is for a lot of different substances to get filtered out of the blood and into this glomerular corpuscle or renal corpuscle. So this is where we have glomerular blood hydrostatic pressure. So the blood pressure in the glomerular capillaries, it's going to promote filtration by forcing water and solutes in this plasma through the filtration membrane. We have capsular hydrostatic pressure. So this is that glomerular capsule now. So the pressure exerted on this filtration membrane is pushing back. It's like a back pressure. We have blood colloid osmotic pressure. So this is because of proteins like albumin, globulins, fibrinogen. They are going to oppose filtration. This is where we get that net filtration pressure. And it is the total pressure that promotes filtration. So the glomerular blood hydrostatic pressure minus that capsular hydrostatic pressure minus that blood colloid osmotic pressure gives us that net filtration pressure. So if we're looking at these glomerular capillaries, we have that glomerular blood hydrostatic pressure, which is about 55, that capsular hydrostatic pressure, which was said was about 15, and that blood colloid osmotic, which is 30. The total net filtration pressure is about 10 millimeters of mercury. If we lose proteins in our blood into this filtrate, it's actually going to cause edema. So there's some kidney diseases where these glomerular capillaries get damaged. If they become damaged, they're more porous, they're more permeable, more things can pass. So if these plasma proteins start to enter this filtrate, it's going to actually affect this colloid osmotic pressure. That net filtration pressure is going to increase. And if that increases, it's going to cause more proteins to be filtered out. So we end up with more fluids also being filtered out than what's going to return back in. So if we lose these proteins, it causes more fluids to actually accumulate in the tissues, which causes edema. Just because of the pressures exerted in the capillaries everywhere else in the body, those proteins play a role in maintaining that different pressure in those capillaries to keep or to pull water back in. So this glomerular filtration rate, this is how much filtrate is being formed each minute. So our kidneys need to maintain the homeostasis of all of our body fluids. So if this glomerular filtration rate is too high, some of these substances, they may pass too quickly that they are not reabsorbed. They end up getting lost in the urine. If that glomerular filtration rate is too low, all the filtrate that was created is going to be reabsorbed. So we're going to be reabsorbing waste products because we're not getting rid of them. And again, it's related to all those different pressures. And that's going to determine that net filtration pressure. So if there's any change in that net filtration pressure, it's going to change that glomerular filtration rate. So we're going to adjust the blood flow in and out of that glomeralis to help maintain that glomerular filtration. Great. We can adjust the glomerular capillary surface area. As this glomerular filtration rate increases, control of both that afferent and that efferent arteriole is going to regulate the blood flow in. So we can constrict that afferent arteriole to allow less blood in at once. We can dilate it to allow more blood in. So those kidneys are going to maintain maintain the blood flow going into those kidneys. They're going to maintain that glomerular filtration rate just despite the changes that are happening in blood pressure. This is where myogenic mechanism, myo means muscle. So stretching triggers contraction of smooth muscle fibers. It's how those smooth muscle fibers work. Anytime they are stretched, they're going to contract. So as blood pressure rises, that glomerular filtration rate also rises because that renal blood flow is going to increase. We get elevated blood pressures, it's going to stretch the wall more of those afferent arterioles. As that blood pressure rises, it causes those afferent arterioles to stretch. As they stretch, they're going to contract. They're going to vasodilate or vasoconstrict. They're going to decrease that blood flow. When that arterial blood pressure drops, that smooth muscle is not being stretched. When it's not being stretched, it causes them to relax. Those afferent arterioles are going to dilate and increase that blood flow, which increases that glomerular filtration rate. It's all maintaining this homeostasis of maintaining this filtrate formation and being able to reabsorb the substances that we need. We have tubuloglomerular feedback. So that macula densa, it's also providing feedback to that glomeralis. And that glomerular filtration rate is above normal because that systemic blood pressure is high. Filtered fluid, it's going to go more rapidly along these renal tubules. So that proximal convoluted tubule and that nephron loop don't have enough time to reabsorb that sodium chloride in water. This is when those macula densa cells, they can detect this increase in delivery of sodium chloride and water into that nephron loop. And it actually inhibits the release of nitric oxide from the juxtaglomerular apparatus. So if there's no nitric oxide, it causes vasodilation. The afferent arteriole is going to constrict when the levels of nitric oxide start to decline, which causes less blood flow into those glomerular capillaries, and that glomerular filtration rate goes down. So when blood pressure falls, this glomerular filtration rate will be lower. It's going to cause the opposite events. This is a lot slower of a regulator, though, than the myogenic mechanism, the just stretching of those arterioles causing those arterioles to constrict. Our autonomic nervous system is also going to play a role. That sympathetic releases that norepinephrine. It causes that vasoconstriction. So at rest, sympathetic stimulation is pretty low. And we use that autoregulation. Moderate sympathetic stimulation, those afferent and efferent arterioles start to constrict. So they start restricting the amount of blood that is going into that glomeralis. The more sympathetic stimulation, like during exercise or during a hemorrhage, large loss of blood, we're going to constrict that afferent arteriole. We're going to decrease the amount of blood flow. We reduce urine output to conserve blood volume, and it allows greater blood flows to the other tissues. Are other hormones that are also playing a role into everything that is happening here. Angiotensin II, part of that renin angiotensin-aldosterone system, reduces that glomerular filtration rate. It's a vasoconstrictor. So it narrows the afferent and the efferent glomerular arterioles to reduce that blood flow. Then that atrial natriuretic peptide, it does the opposite. It's going to increase that glomerular filtration rate. Stretching of that aorta means we have an increase in blood volume. increase in blood volume stimulates that atrial natriuretic peptide. It's going to cause the relaxation of those glomerular mesenchymal cells. It increases the surface area of the capillaries for increased filtration. So these are the different ways that we can regulate glomerular filtration rate and whether it decreases it or increases it. Here, we look at everything that gets filtered out. We filter about 800 or 180 liters of water a day. We reabsorb most of it. Proteins, we reabsorb most of it. Sodium, again, most of it. Chloride, most of it. Bicarbonate, we're going to reabsorb most of it. Glucose, we should reabsorb all of it. If there's glucose found in the urine, that is actually a stimulator or a sign of diabetes, type 2 diabetes specifically. Urea. We get rid of more than half of the urea that we actually filter. Potassium. We should reabsorb all the potassium. Uric acid, most of it. Creatinine. We get rid of all the creatinine that we also filter out originally as well. So the volume of fluids that enter the proximal convoluted tubules in just a half an hour is greater than the total blood plasma volume because the normal glomerular filtration rate is so high. This is why we reabsorb. We reabsorb most of the water, most of the solutes, most of the ions back in. About 99% of that water I said we mentioned in that chart above is reabsorbed. And it's the epithelial cells that are going to help with this reabsorption specifically. Again, glucose is reabsorbed 100%. Those amino acids, urea, sodium, potassium, calcium, chloride, bicarbonate, phosphate. So once these fluids have passed through this proximal convoluted tubule, more distal fine-tuning of this reabsorption process is just maintaining the homeostasis at this point. Most proteins and peptides, they go through pinocytosis to be reabsorbed. Nephrons and collecting ducts also go through tubular secretion. So this is where we're going to take more from the blood and put it into that filtrate. Hydrogen, potassium, ammonium, creatinine, and some drugs. So we secrete out hydrogen to control that pH. Other substances, we try to eliminate them from the body. So different things are going to pass in from the blood into the urine. And this is where we can detect things on a urinalysis. A urinalysis is checking the blood for different substances. So they can check for anabolic steroids because that's going to pass through erythropoietin. Anybody taking synthetic erythropoietin to try to increase their blood volume, blood doping, HCG, growth hormone, amphetamines. It can also check for alcohol and illegal drugs. This is why most drug testing is through a urine test, because we're going to excrete out the marijuana, cocaine, and heroin. So there's different ways that we can reabsorb. They're going to go through one of two different routes. Because as we reabsorb things, it can move between the tubules or an individual tubule cell. can go right through that cell. So this apical membrane is in contact with this tubular fluid. The basolateral membrane is in contact with that interstitial fluid. Fluid that leaks between cells through this passive process is paracellular reabsorption. This proximal convoluted tubule is pretty leaky. And this is where we reabsorb substances between the cells and those peritubular capillaries. So this is a passive process. We have transcellular reabsorption, which means substances are going through the cell's membrane. They go through the apical membrane of that cell, across the cytosol, and out the other side. So they can either just leak on through, or they're going to go through the cell to get back into that blood supply. So when these renal cells start to transport different solutes, they're going to move them in one direction. So sodium, we move large numbers of sodium ions, and they're going to pass through the glomerular filters. Then we have different cells that line these renal tubules. And there's a pretty low concentration of sodium found in their cytosol because of these sodium-potassium pumps that are pumping sodium outside. Sodium is a one-way process. We have to use primary active transport. So most of the time, these sodium ions get pumped into this interstitial fluid at the base of the cell, the bottom portion of the cell. So when we reabsorb different solutes, it causes water reabsorption because water moves via osmosis, so that follows these solutes to try to even out the level of these solutes in and out of the filtrate in the bloodstream. So we have this obligatory water reabsorption. This is water that gets reabsorbed with solutes. It follows other solutes, as we said, through osmosis. We have facultative water reabsorption, and this is the last of the water that gets reabsorbed, and that is that antidiuretic hormone that is regulating this. And it happens in the late distal tubule and through that collecting duct. We are reabsorbing water based on antidiuretic hormone telling us if we need to or not. So when this blood concentration, this is what I've mentioned before. If your blood concentration of glucose is above 200, that's very high. We cannot reabsorb all of the glucose that gets filtered out. This causes glucosuria. That is most common in diabetes. Excess glucose gets filtered out. We cannot reabsorb it fast enough, which as we get rid of glucose, it inhibits water reabsorption. And this is what causes polyuria, or an increase in urine output, a decrease in blood volume, and then dehydration to go with it. So we reabsorb a lot of solutes and a lot of water. So 65% of filtered water happens in the proximal convoluted tubule, sodium, potassium, and calcium as well. Glucose and amino acids, 100% of them are going to get reabsorbed. Bicarbonate and urea. We can secrete hydrogen and ammonium, and urea. Solute reabsorption is going to involve these sodium symporters, sodium glucose symporters, and sodium hydrogen antiporters. Symporters, they're going the same direction. Antiporters move the opposite direction. So in a symporter, both glucose and sodium are traveling through this cell. On an antiporter, sodium goes in when hydrogen leaves. This is how we maintain these different levels, is by letting sodium in or out with the hydrogen traveling in and out of the cell specifically. So this proximal convoluted tubule reabsorbs a large amount of water, and then this filtrate is going to go through the next part of the nephron loop. It's very different. This filtrate is very different by this point. We don't have glucose, we don't have amino acids, and there's a lot of other nutrients that have been filtered out by this point. The osmolarity is still very similar to the blood osmolarity. We can reabsorb more water. We can filter out sodium, potassium, and calcium. We can reabsorb chloride, or we reabsorb sodium, potassium, calcium, chloride, bicarbonate, and magnesium. At this point, this nephron loop, osmosis doesn't happen as easily as it did in the proximal convoluted tubule, because there's parts that are actually impermeable to water. So that nephron loop is going to set its own regulation for that volume and osmolarity of the body fluids at that point. These symporters, they're technically leak channels, but they're going to maintain what is coming in and out. Symporters, again, go the same direction. No water gets reabsorbed in that ascending limb of this nephron loop. So as we go to that distal convoluted tubule, by now we have reabsorbed most of the water. We have symporters for sodium and chloride. We have calcium or chloride leak channels that are going to allow both sodium and chloride to be reabsorbed. So that early distal convoluted tubule, this is where parathyroid hormone is going to cause calcium reabsorption. So reabsorption and secretion in that late distal convoluted tubule in that collecting duct. So by the time we get to the end of the distal convoluted tubule, 90 to 95% of what was originally filtered out has returned to the bloodstream already. Principal cells will reabsorb sodium and get rid of potassium. And that's where aldosterone and antidiuretic hormone are going to play a role in maintaining ion levels. Intercalated cells reabsorb bicarbonate and secrete hydrogen for that blood pH. They also reabsorb potassium. So this late convoluted tubule, it could be getting rid of potassium. They could be reabsorbing potassium as they get rid of sodium. It all just depends on aldosterone, and antidiuretic hormone. Here's this renin-angiotensin-aldosterone system. So this plays a role in blood volume and blood pressure. So as that blood volume and blood pressure goes down, that afferent arteriole, it doesn't stretch well. These juxtaglomerular cells secrete renin into the blood. In it, we have this sympathetic stimulation that also can help release this renin. Renin works to take a 10 amino acid peptide can kind of clip off to make angiotensin 1 from angiotensinogen. This is made in the hepatocytes, so the liver. So we take off 2 amino acids with this angiotensin converting enzyme, or ACE, and this is going to convert that angiotensin 1 to angiotensin 2. This is the active form. Angiotensin 2 can decrease the glomerular filtration rate by causing vasoconstriction. It can enhance reabsorption of sodium in that proximal convoluted tubule. And it stimulates the adrenal cortex to release aldosterone, which stimulates those principal cells in the collecting ducts to reabsorb more sodium and secrete potassium. When we reabsorb sodium, water follows. As water follows in, it's going to increase the blood volume, which in turn increases blood pressure. Antidiuretic hormone, or vasopressin. It regulates water reabsorption by increasing water permeability in those principal cells in that late distal convoluted tubule and the collecting duct. So if we have no antidiuretic hormone, that apical membrane of those principal cells have very low permeability to water. These principal cells contain vesicles that have water channels, or aquaporin. Aquaporin gets stimulated by that antidiuretic hormone, and it actually puts these vesicles bind with that apical membrane, which causes these aquaporin channels to be attached to that membrane, which allows water to follow through. That increases the water permeability to these cells. Increasing water causes an increase in blood volume and an increase in blood pressure. This is all happening because of antidiuretic hormone. And again, it works as a negative feedback. So it's trying to get our blood volume and blood pressure back to a normal size or volume and pressure as fast as possible. So this antidiuretic hormone is causing more water reabsorption when our blood pressure gets low because we're trying to maintain a pretty stable blood pressure. So this antidiuretic hormone in this late distal tubule and collecting duct, it's going to depend on the hydration of the body. During normal hydration, there's usually enough antidiuretic hormone that can cause 99% reabsorption of water. When we're dehydrated, more antidiuretic hormone gets secreted out. About 99.8% of water gets reabsorbed. Overhydration, antidiuretic hormone decreases. So only 80% of that water gets reabsorbed. So maintaining a normal hydration is important to maintain our antidiuretic hormones, but our body has ways to adjust it depending on whether your body has enough water or not enough. Atrial natriuretic peptide, that comes from the heart. It can inhibit the reabsorption of sodium, which causes sodium, and water follows sodium. So if we're not absorbing sodium, we're not absorbing water. It suppresses that aldosterone and that antidiuretic hormone. If we have an increase in sodium in the urine, it's called natriuresis. With natriuresis, it increases urine output or diuresis. And this is what helps to regulate that blood volume. Getting rid of more sodium means we're getting rid of more water, which decreases blood volume, which decreases blood pressure. Parathyroid hormone. Parathyroid hormone is because we have lower than normal calcium levels. So parathyroid hormone is going to work in that distal convoluted tubule to reabsorb more calcium into that blood. It inhibits phosphate reabsorption. So we're getting rid of more phosphate with parathyroid hormone. So here's all these different hormones, what triggers them to be released, where they work, and what their effects are. So we evaluate how the kidneys are working through what is known as a urinalysis. Through the urinalysis, we look at many different things. We can look at the volume of urine. What does it look like? The chemical makeup of it. And then we can also technically look at the microscopic properties of this urine. So we can look at the volume of urine that's being eliminated. We should be eliminating 1 to 2 liters of urine a day. We can look at blood pressure, blood osmolarity, diet, body temperature, diuretics, mental state, and your general health is going to actually influence your urine volume. There's a lot that goes into it because water makes up most of it. About 95% of your urine is water and only 5% are electrolytes, different solutes from different cellular metabolism. And then there's other substances like drugs. So if there's any kind of diseases in the body that can alter your kidney function, we can see different things in the urine that may not normally be present, like glucose is a prime example. So when we look at urinalysis, we can look at volume, how much is being excreted out. We look at the color. A normal colored urine should be, I was told, a straw color, but it can be yellow. It can be kind of amber. Again, it's going to depend on what kind of solutes, ions are being released out. That urea or that urochrome, that is from the breakdown of bile, and urobilin from the breakdown of hemoglobin is what makes up the color of your urine. The more concentrated the urine is, the darker it's going to be. It can be kind of reddish from beets. Different medications are going to play a role into the color. If there's kidney stones, there could be blood in that urine, which gives it more of a pinkish color as well. It's more transparent when it was freshly excreted or voided out. If you let it sit on the counter too long, it starts to become turbid or cloudy. The odor. It should have a mild odor to it, but if it's been sitting for too long, it can start to smell like ammonia. Some people inherit to the ability to form this methyl mercaptan from digesting asparagus. Someone with diabetes, their urine is going to smell more fruity because of ketones. That pH can be anywhere between 4 and 8. It's usually about 6, so it's more acidic. Then the specific gravity or the density. That is the ratio of the weight of the volume of substances to the weight of equal volume of distilled water. It should be between 1.001 and 1.035. You can also do blood tests. You can do this blood urea nitrogen test or this BUN test, and it measures the amount of nitrogen that is found in the blood. And that's because of the catabolism and the deamination of different amino acids. So when this glomerular filtration rate starts to decrease, renal disease or obstruction of the urinary tract, this blood urea nitrogen rises. You can minimize the amount of proteins you take in. The creatinine in your plasma from that breakdown of creatine phosphate in our skeletal muscles to get energy. Creatinine levels should be pretty steady, but because it's going to depend on the rate of creatine excretion in the urine. It depends on how much is discharged by the muscles. It should be about 1.5. If it's above 1.5, it starts to indicate muscle or renal function. So if we have albumin, glucose, red blood cells, ketone bodies, bilirubin, urobilinogen, casts, microbes, it can all suggest different things. Albuminuria, because we have albumin in the blood. Glucoseuria, because there's glucose. Hematuria, there's blood. Ketouria, there's ketones. Bilirubinuria, because we have bilirubin. Urobilinogenuria, because we have urobilinogen. There's a lot of different things that can cause something to be in the blood. Renal plasma clearance. That's the volume of blood that is cleared per unit of time, so milliliters per minute. This is actually more useful than BUN and this blood creatinine value. And it tells us the kidney's ability to remove a substance from that blood plasma. So high renal plasma clearance indicates efficiency in excretion. Low tells us your kidneys aren't doing a good job. So glucose, it should be 0 because it should be reabsorbed. Glucose should not be excreted at all, so we should not see it. And that's can be used to actually determine renal plasma clearance. A drug's clearance, we use that to determine the correct dosage, so how long it takes to excrete out a specific drug. So if there's a high clearance, the dose must be high. We must have a high dose and it must be given several times a day to maintain that therapeutic level. So the clearance of a solute is going to depend on that glomerular filtration rate, tubular reabsorption, and tubular secretion. So a substance that is filtered but not reabsorbed nor secreted, its clearance, that glomerular filtration rate, those molecules that pass from the filtrate through the membrane into the urine. Insulin is a good example. Insulin is used to determine glomerular filtration rate. We can put insulin into the blood intravenously. And then we can measure that urine, its rates through the urine. Creatinine clearance is another way to assess that glomerular filtration rate, because creatinine is normally produced by the body. So it tends to be a better way to go instead of administering insulin into somebody's system. Hemodialysis. This is when somebody's kidneys do not function well. So it's going to remove the wastes, excess fluids from the blood, and it restores the electrolyte balance. So someone whose kidneys function, one or both, is 10% of their capacity. This is what causes renal failure. And the leading cause of renal failure is diabetes. So the blood is removed from an artery, usually that radial artery. It's going to pass through this kidney dialysis machine. Within this kidney dialysis machine, there's a computer that's going to monitor the blood flow, the blood pressure, the blood volume, and other information. It's performed 3 times a week, and it can take 3 to 5 hours to complete. On to the ureters. Our ureters, we have 2. As long as you have 2 kidneys, you have 2 ureters. And this is where urine is going to pass through to get to the bladder. The ureters use peristaltic contractions, that peristalsis, to move urine through the ureter. There's also hydrostatic pressure and gravity that plays a role into how fast this urine is going to pass. Peristaltic waves can go 1 to 5 per minute as this urine leaves the kidneys and goes down into that bladder. They're 10 to 12 inches long, just depending on body size. And they're pretty narrow. They can be 1 to 10 millimeters depending through their course. They're usually wider at the kidney and they narrow as they go down towards the bladder. Again, the ureters are also retroperitoneal. And they kind of travel down your back and across. They go in front of that common iliac artery and vein. There's no value to the ureters. No, there's no valve. Sorry, there's no valve. They just kind of pass using gravity, using these peristaltic contractions to allow this urine to pass through. So these ureters, they come in using these peristaltic waves and gravity to allow this urine to travel into this urinary bladder. They are made up of a mucosa, which is transitional epithelium, that urothelium. Transitional epithelium is made specifically to stretch. There's a muscular layer. Since they do those peristaltic contractions, they must have smooth muscle. Then they have this adventitia, this outer layer, connective tissue, blood vessels, lymphatic vessels, and nerves are found in that adventitia. Now down to the bladder. The bladder is technically a hollow organ. It sits behind the pubic symphysis, and in a male, it's right in front of the rectum, and in the female, it's anterior to the vagina and just below the uterus. There's folds in that peritoneum that help to hold this bladder in place. When this bladder starts to fill, it starts to distend, starts to expand. It can become more of a spherical type of shape. When it's empty, it'll collapse down. So as this urine starts to increase in this bladder, it'll become more of a pear-shaped. It'll start to rise into that lower abdominal cavity. It can hold about 700 to 800 milliliters of urine. So where it sits in the male, just in front of that rectum, so it'll sit through here, and that female, it sits just below that uterus. So at the bottom of the bladder, it comes together to this little triangle that is known as this trigon. And within this trigon is where the urethral opening is found. We have an internal urethral orifice. And this internal urethral orifice is in that anterior corner. It has a muscular layer to it. And within this entire urinary bladder contains different different layers. We have that mucosa, that inner side of that urothelium, which is transitional epithelium, which has that lamina propria underneath it to help hold it in place. That transitional epithelium is what allows our bladder to fully stretch. We have those mucosal folds or rugae, again, to help that bladder stretch. We have a muscular layer that is known as the detrusor muscle. This is an area that the muscle has its own name. That detrusor muscle has 3 layers, a longitudinal, circular, and then another longitudinal layer to it. At the end of the bladder, we have at the bottom, I should say, we have an internal urethral sphincter. This is internal urethral sphincter is made of smooth muscle. And then we have an external urethral sphincter that is made of skeletal muscle. That most superficial is that adventitia. Again, it's helping to connect that bladder to the walls of the abdominal cavity around it. We have that serosa on that superior surface again, which is that visceral peritoneum. So how do we actually urinate? Urination is called micturition or voiding, and that is causing that urine to discharge or leave that bladder. It involves both involuntary and voluntary muscle contractions. So when that bladder starts to fill, when it gets above 200 to 400 milliliters, it creates this pressure within the bladder because this bladder is starting to stretch. We have nerves that sit inside those walls of those bladder, and that's going to send impulses into the spinal cord. These impulses that go into the spinal cord are going to this micturition center in that sacral spinal cord. And this is what gives us that micturition reflex. This micturition reflex causes this detrusor muscle to contract and relax this internal urethral sphincter. Again, that internal urethral sphincter is made of smooth muscle. It inhibits those somatic motor neurons that go to that external urethral sphincter. So when this detrusor muscle is going to contract and relax, and this relaxation of the external urethral sphincter is what causes urination, and that bladder is going to empty. Again, we can hold that external urethral sphincter to prevent urination from happening until we get to a place where we can actually urinate. This is where in children, babies, emptying of the bladder is a reflex. So in early childhood, this is where we learn to control that external urethral sphincter to initiate and voluntarily stop micturition. So cystitis. It's an inflammation of that urinary bladder. It could be because of the bacteria E. coli. Chemotherapy drugs, radiation, long-term use of catheters, that's sticking tubes up into the bladder to drain it out because other sources don't work, diabetes and kidney stones. It can cause pelvic pain, frequent urination, burning, odor, blood, and a fever. This is a bladder infection, is another name for it. Now the urethra. The urethra is the tube from the bottom of the bladder that opens up to the exterior of the body. Males and females both have a urethra. Males, their urethra combines with their reproductive tract that also discharges out semen. The male urethra is a lot longer. So in males, it goes from the internal urethral orifice to the external. The males, it's considerably longer because it has to pass through the prostate, the perineal muscles, and through the penis. So in males, that urethra is close to 8 inches long. It's got quite a long way to go. So they have this prostatic urethra that's going to go through the prostate. Again, it's urothelium, so it's transitional epithelium. We have that membranous urethra that goes through those perineal muscles. Here it's stratified columnar or pseudostratified columnar epithelium. And then we have the spongy urethra that passes through the penis. This is stratified columnar or pseudostratified columnar epithelium at this point. We have a muscular layer that makes up part of this male urethra. In this prosthetic urethra, there's circular smooth muscle. The muscular layer of the membranous urethra is where we have that skeletal muscle fibers that contains that external urethral sphincter. There's a lot of different glands that are attached to the urethra. There's different ducts that are going to secrete into that urethra. We have seminal glands, and the ductus of the vas deferens that comes out through the prosthetic urethra. This is what delivers sperm for the male reproductive tract. These seminal glands work to neutralize the acidity of the female genital tract and allows sperm to move. We have bulbourethral glands that sit just below the prostate. They're going to empty into that spongy urethra and they're secrete more of an alkaline type of substance, again, to neutralize the acidity of the spongy urethra. They also lubricate. And then we have urethral glands that help with discharging a mucus during sexual arousal in females. The female urethra is only about 1.5 inches long. In the female urethra, we have that external urethral orifice that is between the clitoris and the vaginal opening. We have the deep mucosa epithelium that is attached to that lamina propria. There is the urothelium, so there's still transitional epithelium to allow for stretching. As we get closer to that external urethral orifice, it turns into non-keratinized squamous epithelium. There's also this muscular layer, the inner layer of smooth muscle, that external or outer layer of skeletal muscle. Urinary incontinence. This is when you lose the control over micturition, meaning you just can't hold it. Infants and children under 2 to 3 years old, it's normal because the neurons that go to that external urethral sphincter have not developed completely, which is why it takes time for children to learn how to control it. In adults, there's different reasons why it could happen. We have stress incontinence. This happens in young adults and middle-aged females because of weakness of those pelvic floor muscles. Physical stress, anything that increases abdominal pressure, coughing, sneezing, laughing, exercising, straining, lifting heavy objects, pregnancy can cause that bladder to leak. Urge incontinence, more common in older people. This is where you get an abrupt, intense urge to urinate. And then you involuntarily lose some urine. It can be caused by some sort of irritation to the bladder wall, infection or kidney stones, stroke, multiple sclerosis, spinal cord injuries, or even anxiety can cause it. There's overflow incontinence. You hold it too long. You hold it too long that there's an involuntary leakage of urine. Could be because of a blockage, weak contraction of that bladder. So when urinary flow is blocked, or that bladder muscle can no longer contract, that bladder starts to become overfilled and small amounts start to dribble out. Functional incontinence. You have the inability to get to a toilet facility in enough time because of a stroke, arthritis, Alzheimer's disease. If you can find the right diagnosis, you can usually correct it. Kegel exercises are usually a pretty good treatment, and that is training and strengthening those pelvic floor muscles. So these go through all the different parts of the urinary system, where they're at, what they do, and their function. So within our system, besides the kidneys, there's a lot of other tissues that are going to work to get rid of different wastes. They can contribute to this. We have different body buffers. So if we have too much hydrogen, excess hydrogen, these body buffers are going to prevent that blood in your body from becoming too acidic. Our blood plays a role because your blood is going to pick up and deliver different wastes. Your liver does that metabolic recycling, so it gets rid of toxic substances. Your lungs, we get rid of carbon dioxide every time we breathe. Sweat glands, they help to eliminate heat, water, carbon dioxide. Plus we can get rid of salt and urea through our skin. Your digestive canal, through defecation, we get rid of other undigested food wastes. Some carbon dioxide, water, salt, and heat this way as well. So as the reproductive system starts to develop, as everything starts to develop, originally the rectum and the urine or the urinary system kind of work together, and they actually create this urogenital sinus where the rectum and the urethra both have the same opening. This is where we start to come in and we start to resemble birds. In birds, the rectum and the urethra are connected together. So when they eliminate, it comes out of the same place. How we're different, they eventually, by the 8th week, split apart. So that anus and that urogenital sinus have split off into their different openings. The kidneys tend to develop towards the center, and then they're going to kind of travel off to their sides to help, or to get to the one to the right, one to the left. As we get older, our kidneys start to shrink. We have decreased blood flow to the kidneys. We filter less out of the kidneys. Those blood vessels to the glomeruli may become damaged, or they start to decrease in number. Kidney disease becomes more common with age. Your bladder starts to reduce in size and capacity. Those pelvic floor muscles, those external urethral sphincters, weaken. They don't work as well. Urinary tract infections are more common. Nocturia, getting up to go to the bathroom several times during the night. Frequency of urination goes up. Dysuria, painful. Going to the bathroom gets very painful. Have a hard time getting rid of all of the urine in your system. It can cause incontinence, blood in your urine. This is where renal caliculi or kidney stones can develop. It's where crystals, usually calcium oxalate, uric acid, or calcium phosphate, form in the kidneys. Could be because you have too much calcium in your system, not enough water. Alkaline or acidic urine, overactive parathyroid glands can cause these kidney stones. These kidney stones get very, very painful. It's the kind of pain where you cannot sit still. You have to constantly be moving around. From what people who've told me who've had kidney stones, they're constantly pacing back and forth because it hurts to sit still. It feels a little better to keep moving around. If these kidney stones are too large to be passed on their own, there's shockwave therapy. And this helps to break apart or disintegrate these kidney stones. Surgical removal is kind of one of those that's not used as often anymore, but it's still an option. These urinary tract infections. It's an infection in part of the urinary system somewhere. It is more common in females just because the urethra is so much shorter than a male. It can be painful or burning urination, frequent urination, low back pain, especially when it gets up into the bladder and it starts to go to the kidneys. It can really cause some low back pain. It can even cause bedwetting. Urethritis, which is where that infection is in the urethra. Polynephritis is when it goes to the kidneys. If it goes to the kidneys, it can start to scar. It can start to impair the function of the kidneys. Cranberry juice, cranberry pills can prevent E. coli from attaching in the urinary system, and it can cause E. coli to be flushed out. Glomerular disease. There's a lot of different types. We have glomerular nephritis, which is where we have inflation of those glomeruli. It could be because of an allergic reaction. Streptococcal bacteria causes these different toxins that people can be allergic to. These glomeruli become inflamed, swollen. They can be engorged with blood, so they don't filter as well. The urine may start to contain erythrocytes and proteins. These glomeruli can be permanently damaged, and it can lead to renal failure. Nephrotic syndrome or proteinuria. We have hyperlipidemia. We have high cholesterol, phospholipids, and triglycerides in the blood, or hypoalbuminemia, low albumin in the blood. You start to see edema, eyes, ankles, feet, abdomen, because we're losing too many proteins, albumin from the blood, which decreases that blood colloid osmotic pressure. There's a lot, there can be associated with glomerular diseases or diabetes, systemic lupus, cancer, and AIDS can cause a lot of these. Renal failure. Renal failure is where we have a decreased or complete cessation where there's no glomerular filtration happening. There's acute renal failure. The kidneys stop working abruptly. There's decreased urine flow. You get oliguria, which is daily output between 50 to 200 milliliters, and anuria, where we're down to under 50 milliliters of urine excreted a day. Low blood volume can cause it, decreased cardiac output. Those kidney tubules get damaged, kidney stones. Dyes used to visualize blood vessels and angiograms, non-steroidal anti-inflammatory drugs and antibiotics can also cause renal failure. Can cause edema, acidosis, anemia, osteomalacia. Chronic renal failure. In chronic renal failure, it's a progressive. It comes on over time. Usually irreversible. Can be because of chronic glomerulonephritis, polyonephritis, polycystic kidney disease. So there's lots of cysts growing in the kidneys, or some kind of traumatic loss of a kidney tissue. There's 3 stages. So diminished renal reserve. So those nephrons are destroyed until about 75% of them are no longer functioning. There's no signs or symptoms because those remaining nephrons take over the rest of the work. Renal insufficiency. Decrease in glomerular filtration rate. So we have increased blood levels of nitrogen containing waste and creatinine. And then we have end-stage renal failure. This is where 90% of the nephrons are no longer working. So that glomerular filtration rate is down to 10 to 15% of normal. These people need dialysis, and they're possible candidates for a kidney transplant. So since your kidneys are filtering your blood, getting rid of the waste products, they deal with every single system in your body because all of our systems, all of our cells are creating wastes that our kidneys are filtering out and getting rid of. This is everything for the urinary system. Thank you very much for listening and have a wonderful day.